hello everybody. It is now 11, so we're going to get started. Thank you so much for joining us this morning. My name is Rachel Solnick. Today we're going to be talking about PrEP in the emergency departments, closing gaps and creating opportunities for HIV prevention. We also have an illustrious panel here of HIV prevention superstars joining us. We have Caroline Freiermuth. You want to just say hi? We also have Alyssa Schechter-Perkins. We have Kimberly Stanford, Kieran Faria.
I'll do the two-way as well.
And Ethan Coward.
Yeah,
all right, so let's just dive right in. Here are our disclosure information. Okay, so the learning objectives today, three main goals. We're going to review the current PrEP landscape, also with some HIV background. Then we're going to talk about different sorts of ED PrEP models. We're going to show that through a number of cases that we have at each of our respective institutions. And we're going to also explain why what the ED needs to launch a feasible program. So diving into some backgrounds. In terms of epidemiology and the background there. So in the US, approximately 1.1 million people are living with HIV, and a substantial proportion of those, 1 in 7, are unaware of their status, which matters because people who do not know that they have HIV are more likely to have ongoing transmission risks. We also continue to see a meaningful number of new diagnoses, with about 39,000 newly diagnosed HIV cases in 2023. So while HIV treatments and prevention have improved dramatically, prevention is still very far from being a solved problem. Of note, most HIV transmission occurs through sexual contact, which accounts for about 90% of the transmission, but then also important to note too that injection drug use accounts for about 6%. And the final point here is that HIV does not affect all communities equally. Persistent racial, geographic, and gender disparities remain across the HIV care continuum, and we're going to talk about that more in some of the next slides. In terms of current trends, we've made real progress in HIV prevention, but the current pace is not enough to meet the national goals. From 2018 to 2022, estimated HIV infections, new ones, declined from about 36,000 to 31,000, which is a 12% decrease. And this is encouraging and reflects the impact of expanded testing, treatments, viral suppression, and prevention tools like PrEP, which is what we're talking about today. But the key point, though, is that despite this decline, the U.S. remains far from the ending the HIV epidemic that EHE targets, which is plans for reductions of new HIV infections to 9,000 by 2025 and 3,000 by 2030. So we have a really long way to go. In terms of who and the disparities, as I mentioned earlier, the burden of new HIV infections is not evenly distributed across the US population. There's definite mismatches between population size and HIV incidence. So for instance, Black individuals make about 12% of the US population, but account for 37% of new HIV infections, whereas for the white individuals, they make about 61% of the US population, but only 24% of new infections. And it's important to note that this is not about individual behavior alone. These differences are reflective of structural and system level factors, which include things like access to prevention, testing, linkage to care, insurance coverage, stigma, and as well as trust in healthcare systems. And this matters for the emergency medicine because we're often a point of care for patients who face barriers to other outpatient prevention services. In terms of why people need PrEP, so this slide builds on the previous one by showing who among these groups are still experiencing new HIV infections and why PrEP is such an important prevention tool for these groups. In 2022, most of the new HIV infections were still attributed to male sexual contact, so they account for about 67% of the incidence. But there's also been large decreases in that group with a 10% decrease. So good progress there, even though the absolute number of infections remains high. But this chart also shows that HIV incidence in the injection drug use and heterosexual contact has been pretty stable, which means that we're not having the same amount of progress in all of the exposure groups equally. So the main takeaway from this is that HIV prevention has improved some things, but we need to be careful to make sure that all groups are getting improvements. And so, let's see, and also in terms of geographic disparities. So in 2022, more than half of new HIV infections occurred in just 8 states. So those states are California, Florida, Georgia, Illinois, New York, North Carolina, Ohio, and Texas. And this geographic pattern matters because it tells us that HIV prevention needs to be both locally targeted as well as national. The highest burden areas are not just one region, it's not just the South, but it's also the South and large coastal areas and major urban centers. Now, also important to note that the USPSTF task force gives the PrEP a grade A recommendation for all adolescents as well as adults for anybody at increased risk for HIV acquisition. And in terms of what is constituting risk of HIV acquisition, they go into this by saying people who are sexually active in the past 6 months, plus any of the following, which would be a partner with HIV, especially if they're unknown viral load, a recent bacterial STI, and then in terms of the different types of bacterial STIs, and it's basically for MSM, it's any of the bacterial STIs, but then for heterosexual groups, it's bacterial STIs minus chlamydia. So for MSM, it also includes chlamydia. And then it's also for anybody who's sexually active with partners of unknown HIV status or inconsistent condom use. Additionally, it also includes individuals engaged in transactional sex, transgender women and men who are sexually active, and importantly, it's anybody who requests PrEP should be considered for PrEP, and that's because there might be undisclosed risks that they don't want to talk to the clinician about.
Okay, so now we'll talk about PrEP. So, you know, the decrease in HIV incidence has been a real positive trend in the AIDS epidemic, and you see a parallel increase in the number of PrEP prescriptions. So this is the PrEP prescriptions over time, and as you can see, it's increased each year after year. So overall, a success story. When you dive a little bit deeper into the data, though, you see that it's not all rosy. Not all rosy. So there are differences in the populations that are actually receiving PrEP. And the disparities become pretty obvious when you look at the details. So most of the people who are currently taking PrEP are men, about 92%, and it's disproportionately concentrated in white men who have sex with men. So that's the population that has really increased their PrEP uptake over the years. Meanwhile, many of the communities that have the highest HIV incidence, including Black and Hispanic populations, have relatively low PrEP coverage. One way to think about PrEP coverage a little bit more quantitatively is this thing called the PrEP to need ratio. And basically all this is the number of new infections compared to the number of people who are taking PrEP. So a lower PrEP to need ratio suggests greater unmet prevention need. So this is a way to kind of gauge the PrEP need a little bit more quantitatively. When you look at the PrEP to need ratio by race and geography, you see pretty significant disparities. So this is the PrEP to need ratio over time for whites, Hispanics, and Blacks. And again, as you see, PrEP uptake relative to HIV burden has really increased dramatically among white patients over time, but less so among Black and Hispanics. It has increased, but to a much lesser extent. So despite overall growth in PrEP uptake nationally, access and implementation gaps persist in communities that are most highly affected by HIV. Geographically, this map is a little bit, this is from AIDS View. You would overlay this map on the other map of HIV incidence, and what you notice is that the places that have the highest HIV incidence have the lowest PrEP to need ratios. So there's a big, mostly in the South, the southern South and southeastern portions of the United States have very, very low PrEP to need ratios, but other states that have high HIV incidence also have relatively low PrEP to need ratios. Now, looking at PrEP disparities, just like we looked at HIV incidence, it really becomes clear that we're not going to meet our goals. We already missed the goals for 2025. We're clearly not going to make the goals for 2030. And if we want to reduce the number of new HIV infections, we really need to expand the access to PrEP. And we need to engage the populations that have mostly been left out of PrEP expansion. And these are the populations that we mostly see in the emergency department. So we really need to start thinking differently about PrEP implementation, and hopefully that's why you're here. You're gonna listen to some of the models that we've actually implemented in our settings to try and roll out PrEP to the populations that haven't necessarily been targeted. Now, what are the options for PrEP? So at a high level, you basically have two options. You've got daily oral PrEP and you've got injectable PrEP. Now the daily oral PrEP, you have TDF and FTC, TDF FTC and TAF FTC. So this is Truvada and Descovy. These have been around for more than a decade. They've got tons of efficacy data. They work. You have the newer injectable agents, cabotegravir, which is given by injection every 2 months, and lenacapavir, which is given by injection every 6 months. Now, for the purposes of this talk, we're going to mostly be talking, I think exclusively you'd be talking about oral PrEP. Injectable PrEP is very, very exciting, but I don't think any of us have implemented injectable PrEP in our settings. Why are we talking about this at SAEM and not at some other conference? It's because this is where the patients are. This is sort of like the thing that we say about everything, like the patients come here, so why don't we just do it here? But the patients that haven't been included in the PrEP expansion are the ones that we are treating most often. These are patients that really have significant barriers to care, including housing instability, substance use disorders, limited access to primary care, and the ED may be their really only source of continuous contact. So we have the opportunity to intervene in patients that might not otherwise access care someplace else. So we really are uniquely positioned to identify patients who might otherwise not engage in HIV prevention care. Now, there's always the argument like we can't do everything for everybody, and that's true, but a lot of emergency departments have already started the steps towards implementing successful PrEP programs. And if you think about it, if you think about HIV care more globally, you can think about it in this status neutral framework, and the status neutral framework always starts with HIV testing. So if your ED is doing HIV testing, you're already mostly there, most of the way there. In status neutral approach, you basically are branching out from the results of the test. If the patient's positive, you link them to care, start antiretrovirals maybe that day or somewhat after that. On the negative side, the patients who test negative but are still at risk, those are the patients that we're most interested in and going to talk about today. Those are the ones who are going to be eligible for either post-exposure prophylaxis if the exposure was relatively recent, or ongoing HIV pre-exposure prophylaxis.
Okay, so just to kind of set the framework, between the CDC, HIV.gov, several of these organizations have come up with what they call PrEP continuum of care, which really models what we know of the HIV continuum of care. Has anybody heard of that? Okay, I see some nods. Okay, which is good because, like I said, it's kind of a direct reflection of that. It's a pretty simple idea, right? You go from diagnosis to receiving care, whether it's HIV treatment meds, or in this case, HIV prevention meds, retaining that patient in care, and then some sort of either viral suppression or some sort of kind of end clinical game at the end of that. So the PrEP continuum is very similar to that. So we're looking at patients who are at risk for HIV, identifying who is a potential candidate based off of what Rachel was talking about. Or, do they have a high risk, high-risk sexual practices, high-risk injection drug practices, things like that. Then are they interested in PrEP, right? This has to be kind of a voluntary, people have to be interested in starting a daily pill. So there has to be some sort of buy-in from them. Are they linked to a PrEP program? We're gonna go into a lot more detail about what that can look like. And then the last three again, are they starting, when are they starting the medication? Are they staying on the medication? Are they retained in care? And then are they achieving adherence and persistence? Are they maintaining that for however long that they want to be on it? If they're wanting to be on it for a short term, for whatever's going on in their life, or is this something more indefinite? So I wanted to present some very kind of general implementation models, and we're going to go into a lot more detail about this in some cases that we have, and some operational details we'll get into a little bit. But going from left to right is kind of your more traditional, what we would think of, versus kind of moving into more advanced or novel implementation models. So what I think most people traditionally think of in their role in the emergency department is identifying patients who could be candidates for PrEP and then referring them to like a PrEP navigator or appointment or something after the ED visit. Again, that's kind of very standard, pretty low lift for most emergency departments. The middle is just like a slight step up, right? So in addition to identifying your candidates for PrEP after you've determined they're HIV negative, then you can do like a rapid referral. So that maybe that same day saying, oh, we have this relationship with a PrEP provider or a clinic or something, trying to get them into that appointment, maybe in the next hour or so, walking them over to the clinic, saying like, we're gonna like do this warm handoff and literally deliver you to the office, clinic doorstep. It's kind of like one more step. And then the most kind of novel and what we're really trying to present here and talk about is this idea of starting PrEP in the emergency department or upon discharge. So once you've identified that person, either through ED or phone follow-up, with navigation, you can either start them on the meds so they go home with it, or discharge them with the medication, knowing that, again, you've put the pieces in place for them to have that warm handoff to a PrEP provider once they leave the ED. So this is kind of like what the scope looks like, and we're going to go into some details in cases.
So I'm going to present case one. This is the really low barrier implementation PrEP pathway. It is something that you might very well be able to implement in your emergency department today with limited additional resources. You may need to figure out who the right people are. There's probably somebody at your institution on the who could be on the receiving end and who can help with this. They're usually an infectious disease doctor or some sort of public health navigation team that can help with this, but this is a very low barrier way to think about starting a PrEP program in your emergency department. So this case is a 19-year-old male who comes to the emergency department complaining of penile discharge, and he's asking for STI testing. He reports that he has frequent sexual interactions, sometimes heterosexual, sometimes with other men, does not really utilize condoms regularly, and he is concerned that he might have a sexually transmitted infection today. When you go back into the EMR, you see that this is a common practice for him. He comes to the emergency department fairly regularly for his STI testing, and because he's engaging in these high-risk sexual practices. So in the emergency department, it's very easy to perform this STI testing. Ideally, you should be offering him HIV testing, even in the absence of a regular screening program. This is diagnostic testing for him. You can offer him syphilis testing, consider testing him for hepatitis, but he's a really good candidate to talk about PrEP with because he meets the USPTF, you know what the acronym I'm trying to say is, Prevention Task Force criteria by virtue of having had STIs in the last 6 months and by virtue of engaging in high-risk sexual practices. So he's somebody who, if he exhibits interest in it, the ideal situation would be to have a warm handoff. There is probably somebody in your emergency department who would, or in your institution rather, who is affiliated with your state's Department of Public Health and works to link patients to PrEP care. There might be a rapid start type of clinic in your institution. There are probably infectious disease doctors who would be very interested in taking this patient in handoff. And so what you want to do is figure out who is the right person to talk with and make sure that the patient receives their information. And then ideally you would also talk to this navigator who could help link the patient to care. Ideally they could talk with the patient in the emergency department, but if that's not realistic, have them have access to the patient's contact information, whether it's via a paging system, whether it's via a note in the EMR, so that the navigator gets the patient's information, can contact them after, and link them to somebody who is able to provide them with PrEP after the visit. And that's a very simple pathway that you should probably be able to implement in your emergency department right now.
Okay, so this program's kind of on the complete opposite end of the spectrum. So this is a much more operationally heavy program that I built when I was at Mount Sinai. And this was actually immediate PrEP initiation. So these patients were started on PrEP in the ED. And the background here is that we had a really robust HIV testing program that involved health educators that were embedded in the emergency department for about 12 hours a day, Monday through Friday. So we actually had a physical presence there. We had a universal offer of HIV testing that was done by nursing. And the health educators would basically re-engage or engage all patients who were undergoing testing or who had declined testing from the nurse. So as part of that engagement process, they delivered a universal offer of PrEP education. So they basically would tell them a couple sentences about PrEP and ask them if they wanted to learn more. That was combined, for patients who were interested in PrEP, that was combined with standardized counseling and education. They did a quick risk assessment. And then for patients who were interested in starting PrEP, we did all their baseline labs. And the ER is actually really well set up for this because you can get most of these labs back relatively quickly to determine medical eligibility criteria for PrEP. So that's your HIV test, hepatitis B testing, and creatinine are really the main things. So as part of a study with Gilead, we actually provided these patients with 30 days of PrEP. They would walk out with a bottle for 1 month of PrEP, and there was a warm handoff to a navigator. Now, you could certainly do this just by providing a prescription, but this was part of a research study, so we were able to provide them with daily oral PrEP when they left the emergency department. And the idea here was that you basically collapse almost most of the elements of the PrEP care cascade into a single visit while they're in the emergency department. And if you know where the patients are lost during the referral and linkage phase, the idea here is that you can improve the linkage process and the treatment initiation and engagement process by doing it all in one setting. And we did this pilot randomized controlled trial called PrEP, pre-exposure prophylaxis in the emergency department. And we basically randomized patients to immediate start. So these are the patients that basically had pill in hand when they left versus standard referral. So the more low operationally challenging model where we just provide a referral and navigate them to outpatient HIV care. And what we found was interesting and I think a little bit humbling for people who are doing a lot of PrEP work. PrEP is difficult. So it's not, the model was based on something that we've done a lot for substance use disorder with buprenorphine. PrEP is not buprenorphine. So there are really major differences between these two things, but the idea of how to implement them is somewhat similar. So what we found is that starting PrEP in the ED is feasible. You could screen patients relatively quickly. They were interested in PrEP, and you could provide them with PrEP to go with. They were very accepting of screening, counseling, and same-day initiation, but the problem was that PrEP uptake and long-term retention remained really low in both groups. So even though one of the groups, the immediate start group actually got the medication in hand, there really wasn't any difference in terms of the number of patients who were engaged in care at 30, 60, or 90 days, or the number of patients who were actually taking PrEP at those time points. So what does this tell us? I mean, I think for me, one of the important takeaways is that for emergency medicine, starting PrEP in the ED is certainly an option, and in some cases may be beneficial, but clearly it's not by itself really going to be sufficient to meet the numbers that we need to meet to achieve our ending the HIV epidemic goals. So it's more than just the medication. There needs to be things behind that operationally that really help motivate patients and navigate them into continued care.
All right,
so I'm going to talk about a similar model. It's a little bit different. So in RED, we actually have an affiliated clinic that's in the building right next door. It's run by ID, and there's a physician and an NP who see patients there. Initially, when this clinic was rolled out several years ago, the idea of it was, as you see here, this flow chart. When patients come into the ED during business hours, if they have an uncomplicated STI complaint and no other kind of exclusion criteria, they get screened, and then they could go directly over there. And this had several benefits. Number one, the patient doesn't wait for 8 hours in the waiting room to see somebody. Number two, it offloads some of the ED load, so it's supposed to decrease crowding in the ED. And then number three, they get, instead of a real quick visit with an ED clinician where we kind of really quickly go through and do some testing, they get a comprehensive visit where they get counseling and can really kind of go through, okay, this is, go through the risk factors, talk about PrEP, things like that. And so that was sort of the idea of that clinic, and it was quite nice for all involved. And here's some of the initial numbers just to share. In the first couple of years that we were open, we were able to get 550 people who were actually eligible for linkage to HIV prevention, and 78 people started on PrEP during that time, so actually really not bad. But what's been interesting about this model is that over time, it's morphed a little bit, and having this clinic available, we still get referrals and we still get a few people every week who go over to the clinic because they come in during business hours, but the vast majority of the patients who are going to this clinic are now our callbacks. They're people who are coming through the ED and who are getting tested for STIs. And as many of you, some of you probably know, we have a universal syphilis screening program in our ED. And so those folks who test positive for syphilis are actually coming back for their follow-up at this clinic. And so we have it as a resource because it's kind of very closely related to the ED, and our workflows, in the times when they're not seeing the patients that are walking into the ED, they can do all of our follow-ups. And so it's a really nice way to get people in. And we've had a large number of the people who've come back, particularly those who screen positive for syphilis. When they come back for that syphilis treatment, at that time we talk to them about PrEP, and it's a really wonderful opportunity to engage them in PrEP. And we think that may be in part, first because they're forced to have a visit with a clinician who can talk to them about it. Second of all, it may be this moment of awareness where it's like, gosh, now I have an STI. So now it's like there's this immediate in your face, oh yeah, I guess I am at risk. And we did actually look at this. We went back to the ED and looked at people who were screened for syphilis and screened negative, but we gave them behavioral risk surveys. And so we asked them, about what are they doing in their free time. And the people who actually did have indications for PrEP, we offered them PrEP. We said, hey, you've answered your answers from the survey. They indicate that you would be a great candidate for HIV prevention. Do you want an appointment? They said yes, we got their numbers, we tried to call them, and none of them came back. But the people who then were diagnosed with syphilis, they did come back. Because now you have an impetus to come back, right? You gotta come back and get treated, and those people we did often get on PrEP. And so this clinic has become not only a way to kind of get people started on PrEP same day if they're coming in with those STI complaints during business hours, they're presenting to the ED, we kind of offload them right to this clinic, and then they can get directly on PrEP right then. But also all those people coming through the ED who get screened, the results come back later, they then come to this clinic, and then it's another opportunity to get them on. So this has been the model that, although having a specific STI clinic I know is outside of the kind of ability of many places, having somebody within ID or somebody who has an interest in this who can see your follow-ups may be all that you need to kind of really get those people in and connected to prevention.
And so what I'm talking about is actually something like of a twist on Kim's model. So this is the telephone-initiated PrEP post-ED discharge, our TIPT program. This is actually an ongoing research implementation science project that we're developing at Sinai. And the idea is to actually use the existing ED workflow, which is the STI callback process, as a prevention opportunity. So in terms of how this would work, so during the visit, the clinician is ordering the STI testing, which per our order set will automatically include HIV and Hep B testing for anybody who's getting any STI tests. Then when the patient is discharged with the STI results coming back about 3 days or 1 day later and it's positive, this is the moment when the patient is already being contacted by the ED callback team, which for our site is actually a physician assistant. And during that call, they're letting them know about the positive results as well as providing treatments. And so then in the tipped model, the callback PA is using that phone call as an opportunity to notify them, not just to notify them, but to also educate about PrEP, screen them for eligibility, and offer PrEP referral, as well as when it's appropriate to offer them an electronically sent prescription for PrEP. And then the final step would be the HIV navigator, because obviously you're not done after just the 30-day prescription, and they're supposed to be calling back the patients within hopefully about a week or so to connect them to an appointment within a 30-day target. And so to jump into how we would operationalize this in terms of an example case, this would be a 37-year-old male who's tested positive for gonorrhea after the ED visits, and he came there saying that he was asymptomatic, but he wanted testing because he had had multiple partners. And so, as I mentioned, our order set already included the HIV and Hep B that you would need to be able to confidently start PrEP. This patient was actually already empirically treated with ceftriaxone in the emergency department, so that when the callback PA calls them, they can just jump right into the PrEP offer. And then, of course, afterwards, the PrEP navigator will outreach and connect with them for an appointment. So I just wanted to dig into some of these details because I think this is part of the challenge here, is in making it easy for people to do, so it's not something that they feel like, oh, well, I'm not an HIV expert, I'm not going to be doing PrEP. So we worked really hard to try to break the PrEP offer down into all of its components in a very streamlined, easy to follow way. So I wanted to just walk through how we operationalize this in terms of using the note as really the tool. So you can see it starts very small, but in the top part of the note, you'll see that there's actually a clinical decision support, which shows, it spits out the results of the HIV and Hep B. In certain cases, people are still just selecting just gonorrhea chlamydia test and not ordering from the order set, so not everybody will have that negative values for those that they need to start it. And then the note will just tell them that they're clinically eligible or not. Then the note walks the PA through a series of interview questions to see if they are eligible for PrEP based off of things like, do they have any HIV symptoms, which would of course make them not eligible for an immediate start. And then finally, we're keeping track in terms of the metrics here, in terms of the PrEP discussion cascade for verbal education being delivered, referrals, offers, prescriptions. And I also show a tiny snippet of something that we're testing as well to see if it's any added impact, which is a scripted educational blurb that disappears from the note after they deliver the script to help walk the PA through how they can be framing this STI diagnosis as an opportunity to initiate PrEP.
So we've talked a lot about the high-risk sexual behaviors, but again, like we talked about in the beginning, we are seeing a rise in HIV cases amongst people who are using IV drugs. And so how do we make sure that, we're really looking there too? So, we all see these, somebody will come in, they have an abscess, you're like, oh, this will be quick and easy, I'm just gonna do my IND, like put them on antibiotics plus minus and get them out the door, right? But really trying to think about, like, why do they have that abscess? Like, is it because they're using IV drugs? Do we need to go a little bit further into that? And so again, talking about labs that you might need before you're gonna start PrEP, talking to people about PrEP, talking to people about harm reduction, where to find clean needles, avoid sharing them and those kind of things. And we have a very similar program at my site to the one that Alyssa discussed, where there's some navigators in our system. We don't immediately start them in the emergency department, but we can connect them to care pretty quickly. So this is just an order set where people can actually, our physicians and other providers in the emergency department can actually consult the navigator real time. If there is not somebody on duty, so there's somebody there from 8 a.m. till midnight most days, and if there's not somebody there, it'll actually just send us an inbox message so that we can follow up with that patient when we get back the next day. So we have about 14 health promotion advocates that staff both our ED and some community sites. They're really trying to look for patients with complaints that might be related to risky behavior, so things like people coming in complaining of STI symptoms, people talking about coming in for substance use, withdrawal, overdoses, those kind of things. They perform this risk assessment, they look for potential needs of the patients, and then they link them to the appropriate places. So part of that assessment is talking to people about PrEP if they are eligible. As they ask questions, it'll kind of pop up and say, hey, this person might benefit from PrEP. And then they ask them, do you know about PrEP? Would you like to know more? How can we help you there? And then talking about how do you really get your community to buy into this. In our infectious disease clinic, we have a lot of our providers now over there who have started treating people for substance use as well, so that people don't have to go to multiple clinics. So, they're not like, oh, well, we got to send you these substance abuse places, but they've actually started, buprenorphine and methadone and those kind of things within the ID clinic. And then also one of our ID docs is embedded within our substance use clinic. So he has a half day of clinic over in the substance use clinic, where he can really talk to people about harm reduction, getting them started on PrEP, and then treat people who actually have known diagnoses of HIV and hepatitis, again, just so they don't have to make multiple trips. Thinking about the people that might benefit from this when somebody comes in, either to your emergency department or, say you're working out on the syringe service program, talking about comprehensive risk reduction, how do you educate them on that? Performing point of care testing for HIV and hepatitis C, real time getting them those results so they kind of know what their own individual diagnoses and risk might be, and then referring them for initiation of treatment.
So I'm going to talk a little bit about some of the operational important factors, and insurance and the affordability of the actual getting of the meds is really one of the most headachy parts of this, right? Because ideally it should be low to no cost for patients, but actually getting to that point is a major pain in the ass. So commercial insurance under the Affordable Care Act needs to cover in-network the costs of PrEP because it's considered preventive care. So it should be zero cost for the medication as well as all of the associated visits and lab tests. It should be completely free for patients when they're in network. Medicaid is usually no cost, but it's very state dependent. So for example, Mass Health covers all FDA approved oral and long-acting injectable PrEP options, including Descovy, Truvada, and Apretude, with no deductibles, copays, or prior authorization requirements for most regimens. That's not true in all states. Some states have limitations on, for example, which meds are covered, but they're usually low to no cost. And then Medicare, and so, like, for example, before I move on to Medicare, like some states will cover just generic Truvada, some states restrict, newer brand name medications, some do require copays for certain medications, but there's usually a low to no cost option on Medicaid. Medicare Part B also should be covering oral and injectable PrEP meds, and as well as the costs of labs and patient visits, so there should be zero out of pocket. Some of more challenges get to patients who are underinsured or uninsured, but even for those patients, there are options. Ready Set PrEP is a program that is owned by HHS and operated by HRSA, which also depends a little bit on the generosity of some of the drug companies, as well as many of the pharmacies have actually agreed to waive the cost of dispensing these medications. And so it provides either free oral meds for the uninsured patients. They do have some barriers. They need to be proven HIV negative, and they actually have to have a prescription, but it should be a fairly straightforward to get a pathway to getting the meds in hand for patients. There's also manufacturer programs direct from the manufacturers where they can provide medications to patients, and they often cover patients up to fairly generous income thresholds as well. So they're a really good option. And then finally, there's assistant programs through the states that covers labs, visits, and sort of some of the other associated costs that Medicaid on its own may not cover. However, this is not very easy to navigate for patients, and patients get stuck because a lot of times, for example, on the provider side, there's billing errors where they don't code something as preventive, and then all of a sudden, the insurance company is not covering it, or somebody's getting out of network care and their insurance only covers in-network care. Prior authorizations are another challenge that a lot of states require prior authorizations for some of these meds, and that makes it incredibly challenging. So cost is a barrier, but it shouldn't be a stopping point, because if you have access to navigation and can set up pharmacy help and navigation help, you should be able to connect patients to these resources. Some of the nuts and bolts of what you need before implementing a program: you need a champion. You need somebody who is going to be the lead for program implementation, who is there to own the way it's set up, who is there to make sure that there are questions that have answers, to make sure that there are people who are able to reinforce the workflow. If there's barriers, they're able to help troubleshoot. There has to be somebody in the department who understands the emergency department. It should be ideally an emergency physician, not an ID doc, but they're the ones who are the dedicated lead. You need to have some sort of HIV testing program. You don't need necessarily a large screening program, but you do need to have a way of ensuring that the patient you are considering starting on PrEP is HIV negative. In an ideal situation, you would have EHR tools and order sets, like bundled labs, documentation templates, discharge instructions, decision support, referral orders. What you want to do is automate as much of this as possible, so that the clinicians who are very busy doing their clinical duties have this going on as much in the background as possible, and you're not adding to their workload. You need some sort of pharmacy pathway, because the pharmacists are the experts in navigating the barriers on the finance side. They're the ones who are used to dealing with insurance companies, they're used to dealing with prior auths, they're able to help you navigate those challenges. And then finally, you really need clear follow-up ownership, because your providers want to make sure that somebody is going to take ownership of parts, B, C, D, E, and F, to make sure that the patient is retained in care. So whenever you start a program, it's really important that you think about all of the metrics that you want to track. As it was Rachel who talked about, I can't remember who it was that talked about it earlier, but we want to track PrEP as a cascade, sort of similar to other HIV care cascades. We don't want to just know whether a patient was eligible. We want to know what happens every step of the way, because there's going to be drop-off at every step of the way, and you need to know where that drop-off is happening, so you know where to intervene, where to make the processes better. Implementation failure can happen at any point, and you want to really be able to access how can we do this better, and you can't unless you're right from the beginning building in documentation of each of these pathways. It's really important to note that, as we've talked about earlier, there's a lot of inequity in PrEP uptake, and so you want to make sure that you are stratifying by those variables that lead to inequity, so that you know which groups require more work in order to get them involved in PrEP.
All right, so, that was a lot. I know we presented a lot. Like any good educator, I'm gonna remind you what we talked about over the last 41 minutes, and try to kind of bring it home. So in the beginning, we talked about the effectiveness of PrEP. We were focusing, like we said, mainly on the oral medications, because I think that's most applicable in the emergency department. But we know it's effective, we know it's necessary, and you have lots of options, right? 10 years ago, we had to talk you into why PrEP was effective. Now we've determined it's effective, and we're moving on from there. The ED is a great access point. That's why we're having this conversation at an emergency medicine conference. We see all of the patients, as we saw in our 5 case examples, of all of the high-risk folks, which you see at 5 p.m. with your super traction every single day. This is a great opportunity for screening, for education, for referral, and dare I say prescription, which is very much possible. Looking at patient retention, right? Again, you can give them the medications, but if they take it for 2 days, that's not really gonna help them at all. So we really want those models where you can refer patients, where they have that long-term follow-up, where they can get that continuity of care, so you're not seeing that big drop-off in the care cascade, which again is not, getting the patient what they need. And I think, as both Ethan and Rachel have showed, like you really can do immediate starts, whether it's in the ED, whether it's giving them 30 days of the medication to go home with, whether it's a prescription, or all of the above, and then linking them to those follow-up systems so they can continue that conversation and get a refill of their prescription, which would be fabulous. And at the end, we talked about what does that operationally look like? Looking at the workflow of it, defining who owns it, not only physician champion, a nurse champion, a pharmacy champion, right? Somebody in each of these different disciplines who are saying, we really believe in this and we're gonna help you see this program through to make it a success. And then tracking the cascade. So we're right at 11:45. We have some discussion questions, but we also just wanna hear from you guys. If you guys have any questions, we have like stuff to help prompt the conversation. But yeah, I don't know if you guys wanna
Oh, you wanna?
Do you want,
Awesome.
I can, are these on? Yes.
Yeah, I was just wondering if any of you had looked into using like online kind of automated processes. Like Mr. is really big that you don't have to come in. They mail like kits to you for the STI testing and pre-admin testing. They work with folks for getting free PrEP for folks who are uninsured. And I was just wondering if that was like something that had been on y'all's radar.
No, but that's fabulous. We were just kind of looking down the panel like, is anybody? Oh, you? Okay, there you go. See someone just.
Where do I have to stand?
Nobody on this side.
So I think the question about the take-home packets, God, I don't know where to stand now. So we actually we thought about this for exactly that reason, and I think part of the problem with the folks who are with those take-home tests and our population in the ED is the take-home tests really target people who have access. They target people who know how to use a website, who know how to look that information up, who know that these things exist, who know that they need to get tested, and that is not the population that we are trying to reach most urgently in the ED. So we actually tried something, we haven't written it up yet, but hopefully coming soon to a journal near you. But we tried something in the last couple of years where we put self-testing stations in the bathrooms in the ED and allowed people to test themselves. So basically replicated that model, but without having to go to a website, request a test, blah, 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 all that stuff. And a lot of people used them. We had a lot of positives, and then we got them in for follow-up in our clinic and got them on PrEP. So it was kind of replicating that model, but bringing it to the people instead of expecting them to go to a website. I think those kits are awesome. It's a great resource, people should use it, but the problem is, you're talking about these populations who most need access to HIV prevention are also the ones who are probably not maybe aware of the existence of PrEP, they're not aware of the websites where you go request those, they get a kit, they're like, how do I use this kit? A lot of those kits are ordered and then never returned, and so there's a lot of issues with that, and so yes, always a good idea, but I think if we can kind of lower the barrier to access, that's what our goal I think is in the ED, so.
And our local health department uses those sometimes, mainly a lot of the HIV testing. And what they found is that it will get mailed in and then they can't actually reach the person. Like they can't, when they send stuff to the address, they're no longer there, they've not provided any phone number, and then we're like, now somebody's out there wandering around positive and we have no idea where.
Is there anybody here from Columbia? Yeah, so Columbia has this thing called Sticker, which is related to HIV testing, but probably could be adapted to PrEP. It really is more of a patient-driven model. So in that model, the patients actually just scan a QR code and fill something out like on their phone. And then if they're eligible for, in this case it's testing, but if it was PrEP, it would notify the provider that this is a person who's eligible and interested in PrEP. So it puts the onus more on the patient side than the provider side. That's a different type of model. It hasn't necessarily been used yet in PrEP, but probably could be and would be interesting to study.
Hi, I was just going to touch on the online programs. I think, maybe correct me if I'm wrong, but programs like Mr. or Freddie, I think those might be more targeted towards like the LGBTQ community. Then maybe it's not necessarily like a generalized thing that people know about. I feel like it's probably more so in that community where they would probably know about those programs.
I had a question about barriers. I'm not a doctor, I'm a community organizer. I work with strictly sex workers who use drugs, so we would love to have more PrEP. And one of the big barriers to consistent PrEP use is nausea, especially our folks have inconsistent access to food. And so I'm curious if injectable versions have less problems with nausea, or if you're aware of any programs that include some sort of access to food support with PrEP distribution.
Yeah, so the injectables are a really attractive option. It's a much more complicated issue in terms of the efficacy of the injectables is amazing. And basically it's a compliance issue. You know, you give somebody an injection for 6 months, they don't have to take a medication. It works like 100% of the time. So as an efficacy drug, it's great. Could it be paired with food as medicine? Yes. I think one of the problems that, and we see this in substance use as well, that a lot of the patients that are coming in who are using substances or doing sex work are really malnourished. So, you know, if you can pair these programs with things like food as medicine or a program that provides food, that would be great. I don't know of any programs that are combining those two things. You know, the funding for each of them is a little bit different. So the funding for the food part is a little bit more complex than the funding for the HIV side. But this idea of using injectables, I think, is very attractive to a lot of us. It's just trying to figure out how to get it in the emergency. It's just really hard. They're super expensive, and it makes it really challenging to be able to offer those things in the ED setting.
And just the other challenge, because it does sound so attractive as far as eliminating some of the pathway barriers that we've talked about, is most of them have or they have an oral component too. That is, the pill is delivered on day 1 and day 2, and so they actually still have to take a pill on day 2, and so that's actually another challenge. My understanding is that the injectables have short-lived nausea, so it's kind of at the beginning of the cycle, but then it dissipates over time. So I think that could be, you know, a reasonable option for your population. The problem is right now the drugs are hard to access at this point, and that we're sorting out the barriers in as far as accessing those medications.
All right, so I think we're at time, but we'll stick around for another 10 minutes until the next session ends to answer questions. Thanks everybody for coming.